Hold on one
All
second.
right.
Okay. Do you all see a little red recording button?
Yeah.
Yeah.
Awesome. Okay,
All right.
so we are going to go through and do a quick introduction to help those who are watching this video know who is participating in the creation of this video. Chris, why don't you start? I'm just going to go down my list here.
Thank you for inviting us to this meeting. My name is Christopher Hood. I'm the president of the Champlain Valley Education Association. I teach math at CVU.
Lisa?
Hi, I'm Lisa Bisbee. I'm the chief negotiator for the Champlain Valley Education Association, and I'm a special educator at Williston.
Jocelyn?
I'm Jocelyn Bouillet. I'm the school nurse at Champlain Community School and the COVID health and safety coordinator for our district.
Erin?
I'm Erin Keurig. I'm an internal medicine physician and also have a master's in public health and work as a hospitalist at University of Vermont Medical Center.
Great. Leah?
I'm Leah Costello. I'm a pediatrician at Timberlane Pediatrics in South Burlington.
Megan?
I'm Megan Roy. I'm the Director of Student Support Services for the district, and I'm on the reopening team.
Jean?
I'm Jean Jensen. I'm the Chief Operations Officer for the district, and I'm also on the reopening team.
And I'm Bonnie Birdsall, Director of Digital Learning and Communication for the district and on the reopening team. So we are going to kick this off today with Jocelyn introducing where we are and where we're going.
Well, welcome everybody. I'm so glad we are able to perhaps have the first of a few conversations going forward about reopening and answering questions and hopefully helping with some concerns that our groups have. During the school closure, the school nurses throughout Vermont participated in these weekly town halls where we learned each week different things about COVID and what it meant for kids and schools. And so we've been thinking about this since late March, and we've been participating in conversations, and things have changed. And so today we hope to have answers for you, but we also recognize that this can change, and we will continue to follow what we learn about this disease. It's new, and new research is coming out every day. One thing that we always try to focus on is what makes Vermont special and what makes Vermont unique. And so I think that when we are talking about reopening schools, we really want to be mindful about focusing on Vermont. And we're so lucky to have our doctors here who can also speak to that. It's really easy to read the New York Times and get caught up in stories about other places. And when we make decisions, we're basing it on our communities and our state. So we're so lucky, and we're really thankful for that.
Terrific. Thank you. So I'm going to just toss out a question. And this one's for our physicians. Can you, similar to what Jocelyn was saying, from your perspective, can you talk about what you've seen in your work since the start of the pandemic as it relates to children and COVID? And what is it that you think is important for teachers to know about this illness?
I'll take that one since I work most closely with kids, obviously. So as Jocelyn said, here in Vermont, we have been really lucky with our numbers to the point that we actually have not had a pediatric patient hospitalized with COVID. I believe there was a 20-year-old, but no patients under that age. We have held very steady in our numbers of kids. There's been around 50 kids under 10 and around 100 kids over 10 since March 5th. Who've been diagnosed with COVID. March 5th is the day Vermont started tracking data on our testing. So obviously we may have missed some at the beginning, but we've clearly caught all since. And we really just are not seeing we're not seeing sick kids. I have a panel of around 1,000 patients at Champlain Pediatrics, and I have not had a positive patient yet. We've tested. I actually don't know what my other partners have had, but there's been very few. I mean, when there's only 50 or 150, excuse me, across the whole state, it's not a lot. But so that's kids at 19 and under. There's only been about 150 cases in children. So honestly, we're just not seeing it. And if we are seeing it, it's either asymptomatic kids who've had an adult contact. So they were tested because of an adult in the home who has COVID, or that was the case in the Winooski outbreak. There were many children involved in that, but many of them were asymptomatic. And then the other situation that we're seeing is just very mild illness, as pointed out by the fact that we just haven't had anybody in the hospital. That being said, we have fielded question after question after question and concern, and we talk about this every single day in our jobs. So our Vermont Child Health Improvement Program, which is through UVM, has had meetings on COVID. We meet 3 days a week for 30 to 45 minutes and talk about COVID with the Maternal Child Health Department from the Vermont Department of Health, the Vermont Child Health Improvement Program physicians, and then infectious disease doctors up at UVM who specialize in pediatrics as well. And this is available to physicians across the state, the pediatricians across the state, and many other healthcare providers who want to be involved in it. It's amazing. We talk about it, we review the literature, and we keep ourselves very up to date because we are the ones getting all the questions about daycare and camps. And that we really are able to say that we have had daycares open throughout this whole time. We've had daycares open full time since early June. We've had camps open all summer, and we still are just holding so steady in our data. And reviewing the science behind why this is happening, we're really feeling like and this is not just Vermont, this is across the world, but the better studies that are coming out about COVID are showing that young kids really just don't seem to transmit this disease. And I wish I had an answer for you why, but we don't know why they don't transmit it at the same rate that adults do. But the fact that we've had daycares and camps open just show that that's not been the case. So, which is really lovely to share that information. And I share that information every day with parents, and I just see their faces kind of relax, which is a lovely thing to see. And I like being in pediatrics in Vermont right now because I get to share some decent news. So, but that's my experience as a pediatrician, thinking about this and reading about it and talking about it every single day since March. So,
Erin, do you have anything to add?
So Leah and I have been chatting just kind of how I can maybe help teachers from the adult perspective. So in my job, I am a hospitalist. I was caring for our COVID patients during our peak season here, right at the beginning of March through April. And I think the thing of kind of question was, what makes Vermont different? And I have to remind myself when I look at the news and everything that I cannot compare Vermont to the rest of the country. In fact, that if we look at what we are following as far as the percent positive of our test rates are very, very low. So I think the average last week was 0.6%. And if we look at Florida, Texas, Arizona, we're at 20 and 25%. And so knowing that even when we opened up, our levels have remained low as far as the amount of positivity. Yes, we saw a lot of inpatients pretty quickly in March as far as those that needed to be admitted. But I will say since that peak and it came down in April, we've had very few admissions in the hospital from sick patients. So even though we're still seeing some positive tests, we're having 0 patients in the hospital to maybe 1 patient that's there for maybe a day or 2. As far as kind of what it looks like for my workforce and be helpful for what we're doing for personal protective equipment is early on, once we knew we had enough surgical masks to go around, every employee was masking as soon as we entered the hospital. And that was taking care of all patients. We do not wear gowns and gloves and face shields on all patients. We're wearing masks. We have had the ability to test patients when they first came in to see if they were negative. It was called a low suspicion, but screening all admissions. Because that's going to change soon to where we won't know that everybody's negative. And the recommendations now are if we cannot meet 6 feet apart from our patients, to wear goggles or face shield along with our mask, or to ask our patients to wear a mask. But I am caring for, I have medical students that I'm teaching daily that are with me throughout the day, residents that are with me throughout the day, contact with nursing staff and patients, and we are all masking. And so within the hospital, I think the initial stress and fear of COVID came in March. And I think as we became more used to wearing masks every day and coming in contact, that stress and fear has decreased.
And just a clarification, surgical masks are just a basic, simple mask. That is not a fitted N95.
It is not an N95.
Surgical mask, it's just a, if blood were to splash in our face, it would not go through it. So that's what a surgical mask is. So.
A simple face mask.
Okay, thank you. The next question we have is, why do you think it's safe for us to open schools? And, you know, with the understanding that we're starting with the hybrid model.
I mean, I think it goes back to that percent positive rate. I think Governor Scott, as he turned the spigot, has always been indicating as following the percent of our tests that are positive. And even with opening up our state and allowing more gatherings and folks, even in the last month, our percent positive of those tests went from 1.5% down to an average of 0.6% last week. And there's some new article out in the New England Journal of Medicine that just came out this week, looking at countries around the world. And I think Vermont needs to look at those other countries that have similar rates of coronavirus and similar rates of new cases. And it's been shown, I believe it's in quite a few different countries of Denmark, Finland, Singapore, Taiwan, Austria, were able to reopen schools completely when their rates are as low as our rates are. And I think because of that, that's why I feel safe sending my 2 kids who are 9 and 10 back to school, because those rates are so low. And I think the fear for me is when I look at the national news and look at other states that don't have those rates. And I think some schools, and maybe Leah knows more of this, those schools that did open had a community spread that was not controlled, and they did not have good mitigation and did not have the ability to contact trace like we did. So therefore, I think they saw outbreaks in schools. And again, I think Leah might be able to know that a little bit more. But that's why I feel we have the safety to do it now. We have low numbers. And that's going to be our indicator of the spread. And despite us opening right now to where we are with opening our stores and our restaurants and our camps, we haven't seen a spike or change in that percent positive.
The way I like to describe this as I talk with families and look at the literature, and but helping families make that decision about camp and daycare and now school, is really looking at the difference of what we had in March versus what we have now. And I love pointing out that Vermont is so unique, and that we really have to put on our blinders and not look at any other states, because we have to look at Vermont's data. And we have to realize that we've really followed the science in our state. I think Mark Levine has done a fantastic job just guiding our whole state through this process, and Governor Scott really clearly trusts him. So it is a real collaboration between the medical and political community that has led this. But there's several things in place now that we didn't have in early March that allow us to feel much safer about being out in the community, getting our haircuts, sending our children to daycare, and sending our children to school. One of those things is that we have a much greater availability of testing, clearly, than early March. So when this all started and we had to shut down immediately, we didn't have testing available. Not only did we not have testing at that point, but patients who I was testing in March and April, it took up to 2 weeks to get the results back. We are now getting results back within typically 48, sometimes even 24 hours if we test somebody. That is not the case in other states. That is the case here in Vermont. So, and probably just because we're doing less tests overall, but we have the availability to do those tests. That availability will not change when college students come back, because colleges are required to do their own testing. They are not digging into the Vermont state supply of testing. So what's available at the fairgrounds and at like at other Fanny Allen and stuff where you could get testing done, that supply will not be altered by students coming back. And who are being required to test once a week, I believe. But so we have so many more tests, we get them back quickly. And then the really unique thing that Vermont has is this contact tracing, which is really the key part to this whole piece. That they are, once there's a positive test, they are reaching out to all possible, to that contact, to that positive test, and trying to figure out who all of their possible contacts could be, and reaching out to all of those possible contacts within 24 to 48 hours. There was a lovely Vermont edition with a contact tracer last week where she went through what her phone call would be, and her phone call said, like, you've possibly been in contact with someone who's had COVID. Will you need help with rent and food? Like, that is what they are asking when they contact trace here in Vermont, which is incredible. Like, it's incredible. That is the first thing that we offer when contact tracing, but that allows very quick ability to identify and quarantine people who have been in contact with patients. And we are going to have cases. Nobody can say that we're not going to have cases opening schools. But if we do have a case, it is going to be identified quickly and controlled quickly. And so it will not cause a large outbreak. And this is exactly what we've seen as we've seen positive camp counselors and positive daycare providers, is that there have not been outbreaks. The health department has been there, involved, and slowed that spread. So that's one piece that I think Vermont has that's amazing. From the kids' safety standpoint, it's just really back to what I said earlier, which is that kids just don't seem to get COVID at the same rates. They don't seem to transmit it at the same rates, and they don't seem to get as ill. And we just have not seen a hospitalized child here. And we can open schools safely and feel so safe about you being around these students, because our numbers in Vermont are so unbelievably low compared to the rest of the country.
The one thing I would like to add, because I agree with everything that Leah and Aaron said, is the other piece about our buildings being safe. I think that, another kind of the national news story about a summer camp in Georgia where 270 people get sick. Well, after you read the headline and you read the actual thing, they didn't do any of the things that they were told to do. They didn't wear masks, they didn't socially distance, they didn't open the windows like they were supposed to do. And I feel like this is another place where, as Vermonters, we have a large, we're very socially responsible. We follow the rules. We're wearing our masks even when they weren't mandated. And so I feel like our public school buildings are going to be some of the safest places in our state because of all of the steps and all of the mitigation strategies that we've put in place, whether it's the cleaning or the social distancing and masking. And also, really, we are going to be keeping those sick kids home and keeping sick adults home. So really, the people who are coming in the building are healthy people. So I feel like when we think about our school buildings, instead of to be afraid of them, actually be like, I'm going to a place that's super safe. I was going to go to Costco, but this is way better. So I feel like we should really, instead of being afraid of our buildings, I feel, again, I'm ready to send my kids off too, because I think that we've actually done a lot of things as a school nurse. I mean, I'm always like, wash your hands and stay away from the kid who's coughing. And so this is like my year, I think we're going to have a really healthy year because we are doing so many steps. And I think that as a state, we are super committed to making sure that those steps happen.
Can I ask a follow-up question? So, Leah, you mentioned that the kids that you saw or in the outbreak and other outbreaks are asymptomatic. Is there any talk at the state level or at of getting sort of regular testing to catch those asymptomatic kids? Actual COVID testing rather than just the temperature check, which isn't always accurate and won't catch the asymptomatic people?
I think this is a good question, and I'm sure Erin has some public health background on this as well. But the challenge, so those kids were tested because they had a parent who was tested. There is some testing that we do clearly to know who's sick. There's some testing we do to know what's going on in our community and what the spread is and get data and information. Unfortunately, just testing, like saying everybody who's going to come to school is going to get tested once a week, we know they're negative the minute that test was taken. That unfortunately says nothing about that afternoon, the next day. It just is, especially with shortages of testing, while we do have enough, if we were to say we're going to do that for every workplace, every school, every kid who's sick, that we would run out of testing. But it also doesn't really help with, it's that moment in time you're negative. But it's unfortunately just not helpful as a return to work or return to school. I actually have really not been, we've talked about the college stuff. I haven't been as much involved in that, but I know they are. I think that is also just to help provide some level of reassurance to the community that they are being quite responsible with their college students, like Middlebury and Burlington, that bringing college students back in, they are going to test once a week, but that doesn't mean that they're not positive somewhere else in the middle of the week. Does that help answer your question, Lisa?
Yeah, I guess I was, I think I'm perhaps misunderstanding what it would be, but it seems to me that even if it was just like, I don't know, once a month, I know it's not going to catch every single one, but if we could stop one asymptomatic kid from spreading to the teachers and then they spread it to their family or whatever, it's the ones that we can't see or can't easily find that are the ones that I think that are scaring our teachers right now.
So where we have, what we do see coming from China, European countries that had outbreaks prior to us, and then a very big study coming out of Korea that I'm sure that you guys, South Korea, that I'm sure you saw, and these are good studies with a lot of kids in them, that we are not seeing kids as the vectors of infection. So I don't know why. We don't really have a great reason as to why they don't spread as effectively, but they just don't seem to spread this disease as effectively. There's some of these are anecdotal stories, but like a child who went to school in France symptomatic possibly had exposure to 150 children who did not spread the disease at all. Nobody caught it from that symptomatic child, so not an asymptomatic kid. But we don't feel like children can spread the disease from that asymptomatic state the same way that we feel like adults can. So we need our armor, and I know that's what Jocelyn has really called it, and I look at it that way too, that we only bring healthy kids into the school, or for our situation, if we're doing like a routine checkup, if they're sick, we like stop at the door and talk about it before we bring them in. Just to make sure, do we need to have them go home? Do we need different PPE? But you have that health screening as your first step. So kids are not going to be coming in the door coughing, snotty, febrile. The next step you have is your mask, and then kids are going to try their hardest. And we know at times they're not going to wear their mask, but we've screened out all the people who could possibly be sick. They're going to have their mask on. That's their second line. You're going to wear your mask all day, of course. You're going to wash your hands more than you've ever washed your hands in your life. And that's your next set of armor. And then you're going to try to distance yourself, and you're going to try to the best you can from children remain, we feel like 3 to 6 feet, but this is prolonged exposure is what puts you at risk. So a potential contact to COVID is greater than 15 minutes closer than 6 feet together. So if you need to be close to a child to help them with something, you can help them with something and then step away, wash your hands after if you want to. That's another step in your armor. And then trying to keep kids in slightly smaller groups so we know who they could potentially have contact with, maybe doing things like, when we can in the fall, opening windows, spending more time outside. These are all part of our armor so that it's not just testing the asymptomatic child and knowing that they're negative at that point in time. It's actually putting all these pieces together. And actually, I'm going to turn this over to Erin to talk about the Swiss cheese model, because I thought that was a great way to describe this.
So I was just actually reading in my public health magazine yesterday about describing the epidemiology in pandemics as the Swiss cheese model. So when we have a piece of Swiss cheese, we have all these little holes. And as we layer a protective, say your face mask, you add another layer of Swiss cheese, it starts to cover the holes. So each intervention we do adds another layer of protection. So yes, 6 feet alone, okay, that's one layer. Add 6 feet and a mask, that's another layer. Add hand washing, that's another layer. Screening, it's another layer. So once we start getting all these layers, we've now, like Leah said, built our armor up so that if one of those is maybe fallen aside, we still have these other reliable measures to prevent the spread. And so that was, I think, a good way to explain why we do all of these things, because we can't keep 6 feet apart. So for me in the hospital, I can't keep 6 feet apart from my patients. I have, 6 students with me all day long during my 80-hour work week. We can't keep 6 feet apart, but we have masks on. That's our intervention. If I need to get close to someone, luckily I have glasses I wear all day, but people are wearing face shields if they need to get close. Another intervention to just help protect them. And I think the hard thing with the asymptomatic, I don't know the pediatric population is, are they spreading? We don't know. I know in the adult population, we've had some patients, unfortunately, still carry the virus DNA, RNA in their nose. It's dead virus. They're not spreading it, but they're continuing to test positive. And as we learn more about this pandemic, we don't know what that means. Do I think that person is spreading disease? No, but as we're testing, they're testing positive. So you get the flip side too, if you're testing and they're positive, it could be dead virus in their nose, but it's still coming up as a positive test. And so it's tricky to manage the testing, but I think we have to kind of trust the tests that we do have. In the hospital, we test someone who has symptoms as a person under investigation, and we trust that test result. And I trust my negative test results.
I want to jump in with a couple of questions and comments. First of all, thank you for taking the time to join for this meeting today. Really appreciate it. And I know all the educators really appreciate it as well. It's no surprise that there's an incredibly high level of anxiety. We've been living through this since March. It affects all members of our society, but as we're looking at the return to school, it's getting a lot of media attention naturally. So it's impossible to escape reading and listening to countless stories about COVID. And yes, we may hear about a summer camp in Georgia, we may hear about different outbreaks and so forth, but we're dealing with our Vermont situation. I think we do recognize that the conditions here on the ground are favorable. As Governor Scott said, if we can't do it here, we can't do it anywhere. And I know that some level of anxiety will decrease once we can get back in and assume new levels of normalcy, as layered as they may be. But it's a very real concern for many people that school-age students and potentially teenagers as well. We can talk about layers of armor around social distancing and masks. There's a very real concern that those will be very difficult to enforce. So if you are somebody who may be health compromised in some way, or perhaps more realistically, a family member, the association has been fielding hundreds and hundreds of emails. We have started a new Google form where we are taking questions from folks, and I'm not going to take the time right now to go through all of them. Simple questions like, what happens if a student tests positive in my classroom? Am I a primary, as an educator, am I a primary contact for that student or not? I know there have been some descriptions around 6 feet, longer than 15 minutes. I've also heard as long as no one was wearing a mask. So let's start with that first question. What constitutes a primary contact with a student or adult, for that matter, with COVID? And what should an appropriate response look like in that scenario?
Chris, good questions, because I think this is coming up for a lot of us, and I know that school nurses across the state and in our group at CVSD are trying to come up with consistent plans about this. So a close contact is something that the Department of Health contact tracers will define. So we don't get to choose who the contact, who they're gonna, say is a close contact. What we would do is provide the logs of who came in contact with that student, or more likely would be an adult in the building who tested positive. That's why it will be so important for us to make sure that we know where kids are and where adults are. And then an algorithm is coming from the Department of Health on what that means. If it means that the classroom gets closed for a cleaning and a remote learning session of a certain amount of time, or if it means the whole group is tested, the contact tracers are the ones who are going to decide that. It's out of our hands. People can certainly go and take a test on their own, but we don't get to define that. That makes sense?
I'm not sure about how to classify the high risk exposure and how they do that, but I can comment on the anxiety of going into work. So I was there when we admitted our first patient, and then was there during our peak season. And I will tell you, I was freaking out before I had to go to work. I mean, the question was, do I need to write a letter to my kids? Am I going to get sick? Am I going to be be intubated? Am I going to die from this? Because of the national news, the healthcare providers, it was terrifying. I will tell you though, once I came to work and actually went through it, it was such a relief to once, one of my partners said, you have to trust your PPE and you have to trust your partners. And I think we have to trust the science. And once you can kind of get into that new normal, I will say the anxiety level for the nursing staff, for the physician staff, the support staff, all decreased when it became our new normal. Not saying it's hard, I recognize it, it's scary, it's the unknown, but I think looking at the data to say, this is where we are, and that risk of an exposure of a kid coming to school sick is so low in our state that now is the time. I'd be the first to say, as when, hopefully never, our numbers rise, things can change, and I support that. I was the first one to tell my kids, you're not going to school today. We have a positive case, you're home. I think I even talked to Leah about it. I was like, I'm keeping the kids home. And so I think it's true. I think we need to be able to run through it, get people in there feeling, okay, now I know what it's like to wear a mask all day. I know what it's like to stand in line and have my temperature checked when I go into a building, and start to realize, okay, we are not in the middle of New York City during a pandemic. And, with that risk, we do know, yes, you're right. Maybe not everyone will be wearing their mask, but if they are, the chance of it spreading, at least in the adult population, is 1%. If you have one person that has a COVID positive and an adult who doesn't, and they're both wearing masks, the risk of contracting it is 1.5%. We know from a couple, there were 2 hairdressers who worked symptomatically, but were wearing masks. Their clients were wearing masks. And out of 139 clients, no one tested positive. And so for me, it's going back and trusting your mask, which is why when I go to work and I'm wearing my mask, I trust it. Yes, I'm getting close to my patients, close to nursing staff. I probably have at least 50 different contacts of adults during the day, but I trust my mask. And so I think we have to recognize, yes, it's scary, but until we realize what our reality is versus other states, it'll get better. I don't know if that's helpful, but I recognize that fear of not wanting to be those other places.
Yes, we all.
Go ahead, Leah.
I was going to say we all went through that at the beginning, so much fear and anxiety, and it has just seeing our numbers, trusting our PPE, trusting our patients, trusting our staff, trusting everybody around us. And but I did want to point to your question about keeping a mask on. It is challenging for kids, and we are not like, oh, they're just going to keep their mask on. I have to be honest though, I'm in the room usually for a half hour with kids, teenagers, all age kids, 3-year-olds. Some of them do a fantastic job. Mask is on the whole time. I think they even get a little anxious when I ask them to take it off to look in their mouth. But so kids have really shown that they're okay wearing masks. They will need breaks. And if they need a break, they need to be more than 6 feet away from other people. And I think kids are going to loiter in the hall. They're going to be teenagers. They're going to have those moments. We're going to try to limit that by, not me, but you will try to limit that by, limiting who's in the hallway, how many kids can be in the hallway at a time, and limiting, we're going to kids can only really be in the hallway for 5 to 10 minutes so that those interactions are shorter. And again, it's all just our armor so that we're not spreading it. But I think, as Erin really pointed out, it is much more likely, or I think more Jocelyn, it's going to be a positive adult, most likely, that's going to be in the building, not a positive child. Just the percentage in the numbers that we've had. And so adults, if I try my best in my office to stay 6 feet from my other office staff or from the adults, the parents in the office, but I can't. My rooms aren't 6 feet apart, so I am closer than 6 feet to them, and we wear our masks, and I wash my hands.
There have been some recent reports.
I was going to chime in one more thing just about kids and compliance. We've been doing summer school for the last several weeks at Williston and Shelburne, and CVU did camps. And I know for Williston and Shelburne, they did great. And these were kids who were at summer school for SEL interventions. And so if there was going to be a group who was probably non-compliant, this might have been it. And kids were great. And I was just talking with someone like, what do we do if a kid takes their mask off? I was like, well, will they? I don't know. How many times do they take their pants off? Like, they don't. You just say, we go to school, we put our pants on, and everyone, this is your clothing. So I think that I know I have a 4-year-old, and he wants to go, he's wearing a mask. And so I actually think our kids are going to do it. And there will be kids who have different reasons they can't, and we can come up with a way that's positive and proactive to help them. So I watching summer school has been such a good experience because it just was really positive, and the kids loved it. And they're, can I take my mask off now? Yep, we're outside. This is a good time to take your mask off, and they got it. So I think that we need to work on some thoughtful ways of how to introduce mask wearing, and we'll work from there.
I just have a quick question to see if anybody has understanding around new research regarding 3 feet versus 6 feet. I know that's a number that seems to fluctuate a little bit. We've also received questions around face shields as opposed to masks, which may be required for some students who may have hearing issues, who need to see a face. So just those two topics: 3 feet versus 6 feet. What's the latest research saying? And then face shields. Any recommendations or insight around that?
Erin, do you want to take face shields?
I'll take the shields. I don't know about the distancing, but we know that just with any viruses, it's mucous membrane. So eyes, nose, mouth. I personally think if you're going to be the most protected, that would be a mask and some eye covering. There are masks that do have open plastic openings. They're for the hearing impaired, so they can read lips. I don't know if there is a recommendations for a face shield alone. I personally would want face shield and mask, or glasses mask, because I think you then are protecting your mucous membranes completely. I would not feel comfortable with just a face shield alone.
The regulations around the face shield are that it has to come down quite far and go around quite far. There are very specific recommendations around that, either on the Vermont Vermont Department of Health website or the CDC. I don't like face shields personally. but it actually has more to do with my stethoscope, but they kind of bump on your chin. So the clear masks do seem to be the most effective for hearing impaired. But yes, face shields with certain, we can get that data for you, Chris, for sure. What a face shield needs to look like to be effective. Your other question was the 3 to 6 feet distance. And that has to do with studies looking at when we cough, sneeze, speak, sing, how far particles are coming out of our mouth, and that the furthest that they travel is 6, that they seem to, if you look at like kind of an arc, that they come out at 6 feet, but the majority are going to come out in that first 3 feet, where it's only a few distant particles that may travel to 6 feet, especially for younger children. And that's where this has come in, that yes, some distance is appropriate. I think we're unfortunately even going to get new recommendations as we go. We are in a pandemic and this is going to happen. And we are like, you will be the first people, I think medical professionals and teachers are going to be the first ones to hear any change in that recommendation. But the American Academy of Pediatrics does feel like children can be 3 to 6 feet apart, and that is backed in science, and what's recommended by the American Academy of Pediatrics for young children. That's 10 and under.
Is that also for, we do chorus and band, and what will happen, what's the recommendation on those? And I guess this is both to the pediatricians and to the school. How are we going to manage those different instances like a chorus or woodwinds, playing?
Lisa, I'll answer that in a second, but I'm just going to go back to Chris's recommendation because I completely forgot. So there's 2 pediatrics infectious disease specialists up at UVM, Ben Lee and Bill Raska. They're helping with some school opening as well. And Ben Lee met with his school district yesterday and I spoke with him. One thing that he actually suggested for patients, although this is not, or for teachers, excuse me, this isn't going to help so much with the idea of hearing impaired, but that he said if you are unable to maintain distance from your patients and your students, and you would feel safer wearing something called a KN95. That's an not fitted N95 mask. So in the medical field, we go through this very special sniff test to fit those masks around us. The N95s you could buy at Lowe's or a KN95 you don't go through that specific testing. But for teachers who may need to be closer, such as a special ed teacher or a speech language pathologist, that they could wear those as an added protection for themselves. So that's a protection for the adults, not increased protection for those around them, but protection for themselves. So that's called a KN95, and that's something he suggested in his district, which I believe is South Burlington. Mm-hmm. I am so sorry, Lisa. I don't know the latest on sports and music and stuff. We're still having all these discussions, but so I don't want to give a final answer on that, but I really have a feeling that things like music and band, unless it can be like outside, are just unfortunately not the safest thing right now. That's what happened in Georgia. That large outbreak at a camp was like a choir camp or something. I don't know. They did a lot of cheers and singing at this camp. But that's going to spread particles much further. So, but there is a task force, and the recommendations I think are coming out maybe even today on some extracurriculars like that. So look out for that. And the recommendations around distancing are supposed to be coming out on Thursday.
Jump in on the KN95s. We just got about 10,000 of them delivered to the district. So these were from the state. They provided them to us. And we're just going through the the steps as to who those should go to, as opposed to the cloth masks, which each school is providing teachers with 2, I believe, cloth masks. And we did just buy 1,000 face shields because there were some teachers who preferred those for, especially when they're talking to the whole class from behind their desk or from a safe distance, but not when they're right at the desk with the students. So we're trying to provide, and then we have, I think, 35,000 paper masks on order. So we're trying to really provide anything that staff feels will make them safe, because that's.
So we, I'm in a private practice. We have to purchase our own PPE. And I think even in the hospital too, we were trying to really preserve our PPE and reuse it. So some ideas to share with your staff are, I wish I was in my office because they're always right behind me when I'm on the computer in the office. I have several paper bags taped up on pinned up on a bulletin board right behind me. And each one is labeled with the day, and I put my mask in there. And I hang it in the paper bag and to reuse them. And I wear my mask all day, every day. I do a few video visits a day, but I see probably 15 to 20 kids a day, and I might do about 3 or 4 video visits. So I'm wearing my mask all day. And I then, I have to say I've been much more lax about it, but early on I was rotating through those masks. So I wouldn't wear one, I would leave it in there for 72 hours before wearing it again. And then also to preserve the masks, wearing a cloth mask over your KN95, or for us, our N95s, was also allowing us to preserve the masks. That's hot. So and then I wear, because I am in the room with so many young kids who cannot mask, I wear a pair of like construction safety glasses. Like they're just like wrap around glasses. They were like $10. I bought them on Amazon. They're nothing special. They fog up a little bit, but because I don't like the face shield. It also just looks a little weird. So, but I think that's a great idea for standing up in front of the class and speaking. A face shield would be great.
And just the Department of Health did just say that face shields without masks are acceptable for classroom teachers. They didn't feel that it was a good option for students. And it had to mostly do with adults can kind of manage their secretions, perhaps, hopefully a little better than students. So they felt like maintaining, so, you have to maintain the distance and do all the other things, but they felt like a face shield alone. Originally they had said, no, you had to do the mask too, but especially considering people who might be hearing impaired, they felt like a face shield alone would be okay.
In those face shields, I have one that I've used for the last, 5 months. So they can be wiped down with alcohol or a bleach solution and dried. And also in the hospital, we did the same thing early on with all our actually fitted and unfitted N95s with paper bags.
Yep, and it's 10 uses, correct? You can do 10 days. If you did put it in the bag for 72 hours, and then I think.
Honestly, I used it
7 days on, 7 days off. So we have a stockpile to desanitize them.
Yeah. I just use them till not till they're like shredded, but until I'm like, oh, this doesn't look.
And 1 paper mask a day. I use that.
Yeah.
Bonnie, I know you had received many comments from staff. Are there some others that you want to prioritize in the 5 minutes or so that we have left?
Yeah. I mean, a lot have been answered. I'm looking, can I as a teacher expect to return to work with students and not contract the virus with the planned protocols? I think we got that.
I think along those lines, and this is something that Dr. Holmes has said to us repeatedly, and I keep coming back to it, there is inherent risk in everything we do, whether it's driving our car or getting on an airplane on our dream vacation. And so but we can't, absolutely assure people. And I know people want that. I'm going to visit my parents, and I need to know that I'm not going to bring them, get them sick, and that we all want that, and I want that. And so it is hard. And so there is inherent risk in that, and we can't sugarcoat that in any way, and we wouldn't want to. So we do really feel like people have to make decisions for themselves and for their family and decide. But what we do know from Erin and Leah, and I always tell, like, my sister works at the hospital here, and she was pregnant through this whole pandemic and working in the ER, and it would be like, you know, why are you going to work? And she did it. She never missed a single day. And I think about, like, she cried a lot, and we got through that. So I think that reminding, like, there is inherent risk, but we know we have all those pieces of armor and that Swiss cheese. So I think it's a hard thing, and I think that we're going to hear that question a lot from our membership and from people in our building. That, yeah.
I think another thing Erin and I were actually talking about, but prior to this, mostly around our anxiety early on in this, is that I do want to stress to you guys that we in the medical setting are not using any different PPE actually than you're using. So we are not wearing more than you would. If I have an asymptomatic patient who we ask, you know, if you've had any contact and do you have fevers, I wear a mask. They wear a mask, I wear a mask. Because I'm seeing so many children under 2 who can't wear masks, I just keep the glasses on all day. But that's just really for those young kids under 2. So we are not sending you in with less than we wear at the hospital. To that point, and Erin can comment on this more, there have been very few healthcare workers who've gotten sick in the healthcare, from other healthcare workers or from their patients. And early on, we were not testing all patients who came into the hospital. We did not know their status. And even testing a patient, we don't get their status for a day or 2. And so I'll turn it over to Erin to comment on, like, healthcare worker infection rates and that what you're using at the hospital.
Yep, and it's exactly right. I mean, we're not wearing gowns and gloves. It's the mask and maybe the eye protection. We get daily emails from the health network. When I read last week, I think there were 56 employees from the start of the pandemic that have tested positive. And I have been told in those updates that most of that's from a community spread. Of my colleagues, so we take care of all the non-ICU COVID patients. There is 24 full-time and a bunch of per diem. None of us have contracted COVID, and we were taking care of actively very ill patients. And I know none of the ICU docs that have contracted and have been out. And so just, yes, it's just our little N of 1, but in our institution, no one had contracted it using our appropriate PPE.
And just clarifying on those 56 cases, I know 33 of them were in the first, like, several weeks of all of this. And of most of those 33 in the first several weeks of all of this, they were felt to be community spread, not acquired at the hospital. So that's 56 total since March, and really probably just 20 since, and UVM's health network is several thousand. Yeah, 10,000 employees. So,
as I told my husband early on, I feel more comfortable going to the hospital because I have people wearing masks around me than I do going to the grocery store. And I hope, just like Josie said, the same thing happens to school, that's the safe place, because these layers have been put into place to keep that place clean and monitored, that becomes a safer place than the grocery store.
Another thing too, I sent these to Bonnie, but Vermont, well, I think across the country, but there is unbelievable data coming out of Vermont that we are looking at. I look at it on a daily basis. I know Erin does too. They have a daily dashboard, and then they have a weekly summary. The daily dashboard just says how many new cases in the last 24 hours. There's also maps by town. So in total, I live in Heinsberg and have 2 children who will be attending HCS. We've had 11 cases in Heinsberg total since March. But so you can look at, like, per town what it is. It doesn't give any breakdown of age, but but you can really look at the maps, the data, how much testing we're doing versus how many positives we're having. And not only am I just looking at this out of interest, clearly the state and the government and epidemiologists and public health folks are looking at this too. And any uptick we're going to see. That's what we didn't have in March. We just couldn't follow it in that way. But we're going to see an uptick and be able to analyze it really quickly. Okay, is this an uptick because of an outbreak like Winooski that we've got boots on the ground, we're containing this, we're working on it, or is this something that's not going well and we need to really dial it back and keep people home? So there is, take a look at it. It's at least 10 or 15 pages of graphs of just data in Vermont that they're collecting all the time and reporting on.
I will share that with the group and then also with the larger community here. Thank you for that. I imagine Chris might like the data. So it has been an hour, and I am sure that we could have this conversation and continue this conversation. And of course, we have not answered every question. And so if it's okay with you, we'll kind of put a little holder out there that perhaps there's a follow-up to this. Another thought and some other ideas that are in the works is to do something similar, but with kids asking questions and kids at different age spans. So because their questions are going to be different depending on how old they are and kind of what they're focused on. But for now, this has been tremendous and incredibly helpful and informative. I hope it has been for everyone. If there's one last comment or question.
Chris, I can't imagine you fielding all those questions from your teachers. Oh my gosh. Can we help with that? Like,
yeah, so that was exactly going to be.
Okay, you said that and I was like, oh my gosh, like hundreds of questions. Holy smokes. And you're on vacation and like, that's not your job to know that answers.
I got 35 today.
Yeah. Holy smokes.
Yeah, I probably got 20, and some of those were CC'd, but some are completely different. Right. Yeah.
And they cover not just health, it could be FMLA related or schedule related, or I've got a sick family member and I'm worried about bringing the illness home. I mean, that's a really anxiety provoking concept, right? If you have someone who has compromised health at home, but yet you need a job. So you're being forced, people believe it's like, I have to make these two really bad decisions, either go to work or stay home. And it's really...
Chris, would you like to spend, Erin's going on vacation for a few weeks, so I don't know if you want to just try to, that's actually why I asked her to come into this, because I think pediatrics, I can be like, kids barely spread it. Like, I haven't even seen a kid, but Erin can really comment on those high risk patients and families and what to do, and maybe a few minutes doing that be helpful to you for your...
That would be super helpful. We have a lot of those concerns.
Yeah. Again, I'm not the expert, but I was able to kind of go through and look at all the data just to kind of answer those specific questions. And I think as we're going through this pandemic, we're starting to see more how things are spread. But let me, on the community spread of things, hold on, I had to take notes because that's just what I do.
While Erin finds that, Lisa and Chris too, I just want to, Dr. Hunt is another doctor who she's with her kids right now, so she's not on, but we are the medical team for this, and we want to do whatever people need. And so we talked about, we could do this in a building if people want to ask questions as a building group. If we want to do another one of these, if, we're here to help, and we want to, make people feel good about coming to work, or help them decide if that's not what, we're not trying to say you have to come to work. That's not, we just want to make sure that people have the right information to make that decision. So in any way that we can help, if you have ideas.
It might be helpful to have even a virtual Q&A with those teachers, and, invite other people to come to that. And the other part of the questions coming from teachers, and this is more for the district people, are, really more district specific. Like, how are you going to keep kids from traveling to red zones? And then, like, how will you enforce quarantine for teachers who go to those red zones? What's going to happen? How will I get a sub? How can I be out? Will I get paid for those? What days will I get paid for, and what rate? Because we kind of have that, guidance, but it's really confusing. And sometimes it just helps to walk through a couple of scenarios.
Oh, sorry, Lisa.
No, that's fine.
Um,
So it might be that we have kind of the medical version, and then we also have a district Q&A where people could come and get
Yeah.
sort of those more specific, you know, when do I put in for a sub? When do I just teach remotely? When, you know, those kind of questions.
Absolutely. Because I'm thinking if we could have a central, and you guys have it actually, if you have a Google Doc, but if we could, you know, consolidate the repeat questions and start to be able to sort them, we can make sure that when we have these forums, we have the right people sitting around the table. Because it could be that it's a combination of, you know, health and district, or maybe there's going to be a district internal forum or whatever. So definitely happy to do that, and would love to hear your questions. Similar to the conversation we just had with special educators, you know, let's generate the list. We're going to have answers for a lot of it, and other things we'll go find answers for, or we'll acknowledge that there aren't answers yet. But yeah, if we could help you by getting all of those and then figuring out the best way to get the answers to people, that would be great.
So on the household transmission, some of the data that's come out is if there's an individual positive in the household, and so you're living with a sick person, they said there's about a 30 to 35% chance of transmission within that household. So versus, and I believe this is without those layers of protection in place. But then if you are with a positive coworker or close family or friend, a 10 to 14% risk of transmission, again, without those layers in place. They looked at communities that had kind of all of a sudden had these outbreaks, and it was really with large gatherings that were sharing food, they were embracing, they had a long one-on-one conversation with someone that was sick without masking. And so I think we all have that fear of taking it to our loved one, our parents, my mother-in-law, and I can't tell people what's right or wrong for them. I know for me, when I was taking care of the COVID patients and had active disease all day long, I came home, went straight to the shower. I never wore the same clothes to work. Definitely a different scenario, but my kids knew that that was the plan. I know of also other friends out in the United States that have had where they come home, and if they have someone that's sick, they're masking, or they're keeping and if they are sick, they are quarantined in their own room and getting food underneath the door. So they have all these various levels of how to make themselves feel more comfortable. So there is a risk of transmitting at home, but it's not 100% risk. And then those risk factors for those that actually have developed disease, usually it's at least 2 or more risk factors. And mainly those are diabetes, heart disease, obesity, chronic lung disease, and chronic kidney disease. And those that have 2 or more risk factors have a higher likelihood of developing COVID. And majority of those patients, at least 81%, are going to have mild symptoms. 14% may need hospitalization with moderate symptoms, and 5% are critically ill. And I think actually those numbers probably are lower than what we're seeing now because we are testing more. So I think we are catching more folks that have very mild illness. But this is the data from the CDC and kind of in the medical literature right now that 80% will have mild symptoms.
So, Erin, sorry, those numbers are for Vermont or for the nationally?
This is the whole pandemic. And I know people always risk, well, I'm going to die. that's obviously, that's our risk. But really that risk, it's about 2.5%, and it greatly increases above the age of 70. So yes, we have all heard the horror stories of someone in their 30s or 40s passing away. They've often had multiple other risk factors, have had poor health, but the mortality rate greatly increases with the age of 70 and above. Not sure if that's helpful to calm anybody's nerves, but that's. And I think the number, fever is not always going to be the one thing, and I'm especially in adults, but cough is probably the most common first symptom someone's going to have.
And this is kind of a side note, just from the school nurse's point of view, I think we want to make sure people understand that, normally we're pushing kids to get through the day, and we are like, you can do it, just a little cough, here's a cough drop. And I just want to be clear that this is going to be a year that's very different for us, and we're trying to wrap our heads around it as school nurses because it goes against, what we believe in. But this will be the year that those kids are going home. And Dr. Holmes has been very clear. She said, this is a pandemic and you go home. If you are sick, you are not encouraged to push through. And
she keeps saying no attendance awards this year.
Yeah, no attendance awards this year. And, we are still trying to work out what that looks like, especially, Chris, you can probably imagine at the high school level, kids have this, maybe self-induced pressure to be at school and get their work done and they don't want to miss. And so we are trying to be creative with how to help kids and staff feel okay to stay home, because we can't be encouraging people to come into the building if there's any doubt. This is a unique time and we have to think a little bit differently. So.
I saw from coming out permanent sub in Shelburne. Is that happening in all buildings?
I think that we're trying to kind of brainstorm some ways to have consistent people in the school that we can rely on. And so I don't know what all of the different schools are trying, but I did see that posting. And I think that I was talking to Patty Spagnolo today about it, and she said, yeah, the thought is trying to keep, get people lined up and keep that. So,
yeah, what we're doing is exploring even, and I mean, to the extent that these folks are available. But it would be great to have licensed subs available to every building, designated to the building. Whether or not we can achieve the license part, I'm not sure, but it is definitely similar. We have a posting open to just hire additional nurses for the district, hire, not substitute, so that they can be available for substituting. Obviously, we need to make sure we have nurses in the building this coming year. So, but we could use a similar model for elementary age teachers and middle school teachers and high school teachers, just to be able to do that. So definitely trying to stay ahead of that potential issue, so that when people need to be out, they will be out. Well, because they're going to be out no matter what. What we have to do is figure out how do we cover them inside.
And I think we all have the same goals, which is like the health and safety of children, and your health and safety. But for the fact that I have not seen COVID at all, I have seen a significant amount of teen anxiety, depression, kids in risky situations, that I think also, like, I have not seen a single child with COVID, but I have seen those things over and over and over again. And that feels scary to me. And so working together as a health community and as a education community to really best serve these kids is just so important. So.
And we view the teachers in the school systems as essential. And I think, I've talked to all of my colleagues, you are essential workers, and we need to find ways to support that. And it is hard and it's scary to realize that a lot of people are relying on this community of teachers and educators, but we as a community and whatnot need to support them, because this is essential. And I think teachers need to know we all stand behind them and we understand their fears, and we're here to help and support them in any way that we can.
Wow. I might use that as our ending. We're going to stop for now. We did outline a whole bunch of next steps, and I will send a follow-up email to everyone, but want to definitely thank you so much for your time, for your expertise, for your knowledge, for your questions, and for being here today and every day. So.
Perfect. Thanks, guys. It was really helpful to have you here.
Thank you. Please reach out. Like we're here to help. So
perfect.
And it was nice to meet you.
Yeah, same.
Take care. Good luck. Stay dry.